Welcome everyone to DDU Teaching. Today it's me, Ben, presenting on adult congenital heart disease. And I'm going to try and present this in a sort of story of two parts. The first part is presenting it in a structured way to approach congenital heart disease. And then the second part has some cases and things as get through, like to try and get through towards the end. Congenital heart disease is not easy. It's not easy for anyone outside of congenital heart disease specialists, and even then it gets more challenging. It's not easy for conventional cardiologists, and it's not easy for anyone else. The fundamental principles, especially when someone is sick, is just keep the blood flowing and make sure you know where the blood's going. So with that in mind, I'll get started. Don't forget also, whenever you see these patients in a critically unwell setting, they're going to be behaving a bit differently hemodynamically. Flow through shunts and through baffles and through valves will all be different. So applying the rules that you use to assess severity of valvular lesions of cardiac function can be challenging. Obviously, if someone's got a prosthetic valve, be that a metallic valve or a bioprosthetic or tissue or anything in between, there will be some standard tables of severity, gradients and things that you can use to assess what the flows and things should be. But if you've got flow in a pattern that is not normal, but is normal for that particular patient, then assessing severity of anything can make it more challenging when they're critically unwell, when they're volume depleted, when they're on inotropes and vasopressors. The more you know about the patient before you start scanning them, the easier it is to report. And virtually everyone, by the time they get to be an adult, has had echoes before if they've got congenital heart disease. I say virtually everyone because it's not everyone. You will be in a position where you may discover some de novo congenital heart disease. Typically, if you're doing that for the first time in an adult, then it's not as complicated as the stuff is that is found in the utero or in utero or neonatal period, but it can happen. So just a couple of boring number slides, just to give, I guess, a better idea as to why this matters even in an adult DDU program. So it's kind of common, right? So, almost 1 in 100 have some form of congenital heart disease. The most common lesions are VSD followed by an ASD. I suspect that's not surprising to anyone, and then a patent ductus arteriosus. So got numbers there on the side. You can see how common the septal defects are compared to everything else. About 1/3 of them are due to genetic disorders or chromosomal anomalies. However, about 50% of all hospitalizations for people with congenital heart disease occur when they're greater than 15 years old. So, these are adult patients and they're living longer now. They're living longer because we can pick things when they are younger, including in utero. We can start surgical repairs within days of being born, and we have better outpatient management. So they present when they're adults with their repaired complex anatomy. And with that, knowing what you're looking at before you start looking is really useful. So a lot of people get fetal echoes now, becoming more common, at least in first world countries like Australia. So just as examples, if the mum has structural cardiac disease, then there would have been a fetal echo done, or if there's a sibling. And these aren't the only two situations in which there'll be a fetal echo specifically performed to pick these diseases. There's many others, but they're just some common ones. So if you've got a sick 16, 18, 21-year-old in front of you, and the mum's had some structural cardiac disease, then you should be able to go through and find, might take some effort, but find what has been done in the past, because this patient in front of you should have had studies done before they were even born. So old echoes are invaluable. And don't forget that genetic syndromes have some characteristic cardiac lesions. I've just listed one there, with trisomy 21 or Down syndrome and having an atrioventricular septal defect, but there's many others. And again, if you know the genetics of a patient or the syndrome of a patient, you can go through and work out what the most common congenital cardiac lesions will be. Useful when you're actually scanning, and also useful for some things like the ASE boards, where there's always a few questions on congenital disease. So I like to take a stepwise approach. So that's what's the position, what's the axis, what's the situs, because they're all kind of easy. And then what joins to what. And then last thing is looking at the baffles. So baffle, for those that don't know, is basically just a conduit. I'm not exactly sure why they're called baffles in congenital heart disease. If anyone knows, please let me know. But it's basically a pipe to get blood from one place to another place, replacing them as a way to shunt it around rather than just have it pass through normal structures. So you might have a baffle that lets blood flow from one chamber to another when it normally wouldn't be there, or from a pipe to somewhere. So with regards to position and the orientation or the axis. So positions where the heart is in relation to the patient's chest, right? So left position is normal. You can be right position or dextral position, and there's midline. So this will shift around. It can change in patients because of other things. So that can be significant obstructive lung disease, for example. Those big COPD patients will get a heart that shifts more towards the midline because as the lungs hyperinflate. If someone's had a right lobectomy and pneumonectomy, the heart will shift across. So the position moves. It doesn't mean anything really, except that getting the pictures might be a bit more challenging. However, the orientation will not shift with time, and the orientation is important. So this is the axis of the heart from the base up where the atria are down to the apex. So is that running towards the patient's left? Is it running towards the patient midline, or running towards the patient's right? And that's how you get your levocardia, which is normal, your dextrocardia, or your mesocardia. And that's how the person was made, right? That's how they were born. That does not shift over time. The next concept is talking about this I've got in science that it should be situs, the visceratrial situs. So that is how what's below the diaphragm relates to the heart. Okay, so normally we have liver on the right, stomach is on the left, and we have our vena cava connecting to the right atrium. That's normal, right? Situs solutus is called. When you've got situs inversus, then the internal organs below the diaphragm are sort of around the other way. It's predominantly stomach, liver, spleen, and appendix, but the heart still sits the way it's meant to. So that is your situs inversus, but your heart can still be completely positioned appropriately with respect to those organs. And then you can have your situs flipped around again, right? So you have your dextrocardia and your levocardia with that. There's a thing called situs ambiguous, and that is characterized by lack of situs, which is just everything sort of in the middle. And with that, right isn't always right. So this is where you get to defining structures. This is defining what is the right atrium, morphologic right atrium, what is the morphologic left atrium, right ventricle, left ventricle. Because that's one of the challenges about adult congenital heart disease, is that what you're looking at on echo, it might be on the patient's right-hand side, but it doesn't mean it's the right ventricle. So there are some kind of rules and guidelines to keep in your head. The IVC will drain to the morphologic right atrium. So the right atrium will have some pectinate muscles. It'll have a really broad appendage, which you can actually see on both transthoracic and transesophageal echo. And I've just got to point out there on the slides on the right, the picture on the right. The coronary sinus associated with that. Left atrium is smooth walls, finger-like appendages, they describe it. So identifying your left and your right atria is a really useful base, because then you can work out your plumbing around that. You then go to what are the valves and what are the ventricles. And so the tricuspid valve is the valve that's associated with the right ventricle. So if you can identify the tricuspid valve, then you know what the right ventricle is. So you can go, all right, here's my IVC. What that's connected to is my right atrium, irrespective of what side of the patient it's on. And then you've got your tricuspid valve, and that's connected to your right ventricle, irrespective of what side of the patient things are on. Mitral valve goes to the left ventricle. So you want to look to identify the patient's tricuspid valve. So the septal leaflets will always attach more towards the apex of the heart in the tricuspid valve, and there's no attachment from the mitral valve to the septum itself. Other ways to help pick the right and left ventricles, where the right ventricle has a moderated band, left ventricle won't. So that way you can go, you've got your pipes, you've got your atria, you've got your atrioventricular valve, you got your ventricle, and then you go, all right, cool. All I need to work out now is what's coming out of where, because this way you know what the blood flow is. And so then you can go, all right, I know what my normal blood flow is. I know what I'm seeing in this patient in front of me who's got some unclear congenital heart disease. And then you can work out what's been repaired to keep the patient alive if they're an adult. And that's where you talk about atrioventricular discordance. So last of all, you look at the outlet. You look at where is the blood going from the right ventricle and from the left ventricle? So is it going where it's meant to? So your right ventricle is going into your pulmonary trunk. Is it going the opposite way? Is your right ventricle going to your aorta? Do you have a double outlet, as pictured there on the bottom left, where you've got sort of it overrides such that one ventricle can pump blood out into both vessels? And then you look at your septums. Okay, so is there an ASD? Is there an ABSD? Is there a BSD? So again, it's just a structure, right? Where's the heart sitting? Is everything like what's the alignment of stuff? Is everything plumbed into what? If you are scanning a congenital heart disease patient in the outpatient setting, so they're not critically unwell, then the referral will often say next to nothing useful apart from maybe congenital heart disease. So just because you find a pathology doesn't mean that that's the only pathology. Go looking through and make sure like you have that systematic approach to work out if you're missing anything. And this is why it matters, because congenital heart disease is a lifelong problem. And by the time they get to adulthood, they have not only the standard like ischemic heart disease risk factors, they can have valve failure, rhythm failure, structural failure. All right, that's the overview. Let's talk about some diseases now. So VSDs or non-ischemic VSDs, the most common congenital heart defect is sort of how they describe it, although I think the bicuspids might be sort of pushing that. They can be alone or they can be with other things. When I was trying to learn like the anatomy of a VSD, I found it quite challenging because different textbooks use different terminology to describe the same thing, right? So I eventually sort of tried to get rid of all the different labels and just keep it simple. So there's membranous. If you ever see a VSD, you're showing one in your DDU exams or something, and you're not quite sure where it is, if you're going to have a guess membranous, because 80% of them are going to be membranous. So that's like the fallback guess if you don't really know. Next is muscular, and they can be anywhere, like anywhere that's not any of the other three. Then there's outlet and inlet. So looking at it from a schematic point of view, the picture at the bottom is where you can see it on echo to help try and identify it. And I think that the parasternal short axis view is probably one of the more useful views to try and pick some of these things. And that's where it sits with respect to the interventricular septum. If you were to take a heart and sort of slice it down the middle and look for where the holes are. Things about VSDs, you want to know where it is, you want to know its size, you know how the blood flow is, if it's involving other structures, and then just the flow and effects, as you do for any like valvular lesion, really, like one of the flow and effects, upstream, downstream. VSD is the same. You want to think about left atrium, you want to think about the right heart. So you consider flow direction, consider quantifying the shunt, and I've got a slide on that in a second. And remember that if you get a really nice alignment, you can get, or if the sonography gets a really nice alignment and you're reporting it, then you can actually determine the pressure gradient across your shunt. The sequelae of a VSD really depend on someone's hemodynamics. So a small VSD might have pretty high flow through it, but if there's not a whole lot of blood, if it's high in velocity but not high in volume, then their developmental effects on the heart because of that may not be necessarily significant. So you can find, I'll say, asymptomatic or almost insignificant VSDs in adult patients, and they don't particularly mean much. They need to be surveilled, but they don't necessarily mean a lot needs to be done. Even some childhood repairs, they can be incomplete, so there'll be residual, very small blood flow through it, despite the fact that they've had, you know, the sternum split open and had a whole lot of other stuff fixed. So QPQS, this you'll come across in the physics components already. So it's really just checking what the blood flow is, how much blood flow is going out through the right heart, how much is going out through the left heart. If you've got more going out through your right heart than your left, it means you've got blood somehow sneaking back into the right heart without going through your left ventricular outflow tract. Great example of that is if you've got a VSD, blood's going from your left ventricle into your pulmonary circulation. So you're not measuring that when you measure your QS of the QPQS. So your QP will be higher. It's got its normal blood plus the extra blood, and your QS will be lower because it's not having that blood that's sneaking into the right heart instead in those calculations, because we're measuring through our outflow tracts. So hopefully these clips play. So I've got a few different clips now. Anyone want to volunteer to describe what they see? I've got a bunch of VSDs among some other stuff. It's not complex. The bar will be set low, I promise.
So these are the toe images, mid-esophageal view at 0 degrees
Yep.
with the heart in 4-chamber view. There
Yeah.
appears to be a defect along in the probably looking like a membranous VST with the flow jet coming from the left towards the outflow tract towards the RV
Yep.
and
Nice.
potentially causing mild RV dilatation as well on the second image.
Very nice. All right. You happy to keep going, Rishi? I'll show you a few.
Yeah.
These are different
So
patients, by the way, so don't think it's all the same patient.
okay, so this is a toe image, mid-esophageal view along axis at 134 degrees omniplane. What I feel is now this aorta is overriding to the right ventricle, so we're potentially looking at Tetralogy of Fallot. So maybe potentially there is a VST at the top of the interventricular septum, but I'll probably need a color flow Doppler to see if there is any jet over there. I
Might have that for
can't
you.
see a pulmonary vein, pulmonary valve. I can't see it properly. I'll
There you
see.
go.
Um,
There's color in.
yeah, so there is a membranous ventricular septal defect with associated hypertrophy of the right ventricle. There's a prominent moderator band. Along with that, there is overriding of the aorta. But I will probably next like to interrogate the pulmonary valves to see if there is any or any better view of the pulmonary valve to see if there's any pulmonary stenosis.
So you think this is tetralogy?
I think so, yeah. Maybe, I don't know. There is overriding of the aorta, which is going into the right ventricle. There is a VST. There is right ventricular hypertrophy.
Are you sure
The
that
fourth component.
can I ask you what makes you say there's override of the aorta? What does that mean?
I think if you see the right side of the image, if you see the two cusps of the aortic valve,
Through
if there
here?
is an enlargement of the aortic sinus, yeah.
Yeah.
I think some of that could be the RV outflow tract as well.
Okay.
Yeah, here you see the aortic sinus looks dilated, or that is overriding into the RV outflow tract. Or there is a eccentric mild aortic regurg. But there is the commissural line is not in the midline
Yeah.
as well. So there could be a bicuspid aortic valve with aortic dilatation. So it could be a bicuspid aortic valve with post-aortic
So
dilatation and
this
aortic
is
regurg.
this is the same patient now as what you've just seen those last couple of pictures of?
Okay, so I'll modify my diagnosis too. So this looks like there is a aortic root dilatation.
Yeah.
There is eccentric commissural line of the aortic valve. So I would like to look at a short axis view to check for any raphe or any bicuspid valves.
What's going on here?
Yeah, is there a color flow there? I can use it. Is there that's aortic sinus?
There you go.
Yeah. There's just there are the two things which can happen. So first is there is a VSD just below the cusps, or
so just
if
through
I
here,
can
where
through here.
there I can see where that bit of color, that funny color is.
Yeah,
You can
that
see on the
goes
previous
below the
shots.
cusp, I think.
Yeah.
Just the VSD, membranous VSD.
And what's this structure? This thin linear structure.
That is the right coronary cusp. And is
Yeah.
there a fistula there? I'm not sure.
I don't know. Yeah, this is VSD, right? So you've just got blood flowing through there. But on the other angles, it does look, it looks like you're going to be having some RV flow project out through the aorta, but it's just all angles. Don't forget you can get prolapse of the sinus of Valsalva as well to lead to some of this
It does
stuff.
look like prolapsing into the right side there.
Yeah. And then if you look here, so sorry, obviously there's a bit of translation through here. You can see as the sonographer's taken the pictures, they've sort of slid the probe a bit, which is why it looks like it's a bit, you know, the cusp look a bit thick. But here what's happening is that you're getting, it's like the right coronary cusp sitting up through here is just starting to prolapse down into that, into the ventricle. This is a different case. So before I ask you if you know what this is, when someone has a VSD, and this is something that can take a bit of time to get your head around, or is easily overlooked, I think, because it's not the necessarily logical thought process. When someone has a VSD and you've got blood flowing from your left ventricle to your right ventricle, agree? Like assuming that you don't have ice and mangas and reversal, you're going to have blood flowing from your left ventricle to your right ventricle. So which chambers dilate? And why?
So initially there is right-sided volume overload. So right side, there should be dilatation of the right side, but at the same time, there could also be increase in the LV and diastolic volume. Is that?
So you say right side, right atrium, right ventricle.
Yeah. Sorry, what was your question?
You're saying right side, so right atrium or right ventricle? And why? Why does the right atrium dilate? Why do you think the right atrium would dilate?
I mean, it can't hypertrophy, so it will dilate.
Okay. So what people can have with a VSD is when, and this is the way it's been explained to me, and so I'm pretty simple, so it's the way that I remember it, is that when the left ventricle contracts, or the left ventricle, assuming you don't have profound right heart pulmonary vascular abnormalities, the left ventricle contracts, it's got a hell of a lot more pressure in it than the right ventricle does. And the left ventricle contracts with so much force relative to the right heart that it's the LV that drives the blood up and out. Like it's the force of the LV contracting that will drive that blood up and out through the RVOT and up and out into the pulmonary circulation. So even though the blood passes through the right ventricle to get into the pulmonary circulation, it ultimately ends up being your left heart that sees a greater volume, because your left heart will see all the blood going through the natural right heart circuit, because that's just the way it's going to go. And it will also see the bit of blood that is squeezing out through that VSD, sort of coming through the RVOT into the pulmonary circulation. So your pulmonary circulation gets more blood, and then your left atrium, left ventricle get more blood. So your LA-LV actually get a volume load before your right heart develops a volume load, which is, in my mind, is kind of counterintuitive, because you think that if the left ventricle is squeezing blood, it's squeezing into the right ventricle, and the right ventricle is going to suffer from that. And I've seen well-established senior cardiologists disagree amongst themselves about this, but this is what the textbooks describe, and this is the natural history that's seen. So it's counterintuitive, but it'll be your left heart that can get the volume overload. However, because of that strong pressure differential between your LV and your RV, the blood is driven into the RV with a fair bit of force. When that blood is driven into the RV with a fair bit of force, it's going to impact against part of the RV. And when it impacts, it can effectively cause like a shear or a pressure injury. And so you can get what is like it's a double RV. It's a double chamber RV is what they call it. And that's what this is a echo image of. So this is a transesophageal echo image. We're at we're a bit round from a standard aortic short axis picture around at 80 odd degrees, and we're looking at the pulmonary valve there. And you can see the pulmonary valve is sitting here nicely. Like that's where it is anatomically. You can see it quite well, all things considered, I think. But you can see again this flow acceleration in the like the RVOT or the subvalvular region. And you have two patches of flow acceleration, one down here and then one in here. And what happens is over time, after exposure to that high velocity blood every cardiac cycle, a small portion of your RV will effectively suffer from that and hypertrophy from the sheer trauma. And so you get this sort of second little chamber. So it's a double chamber right ventricle. It's very uncommon sequela of VSD. That's like the bonus points mark that separates out the elite people from the ordinary people on the American boards. I am absolutely one of the ordinary people. I'm not going to talk about ASDs very much because I think there's separate lectures in the like DDU education program about them. But I do want to mention them because just like VSD, although it's not sexy, cool, really interesting congenital stuff, it's the most common congenital stuff you're going to see. So it's the stuff you have to know. So, you know, there's primum and secundum, sinus venosus defects, unroofed coronary sinus. So, you know, again, I'm not going to labor over the shunt volumes and the complications of ASDs because there'll be other talks about that. But there's the anatomy of them. So where you get a secundum, where you get a primum. A primum is also called a partial AV canal defect, coronary sinus defects, and the venous sinus defects. Just a very quick one though about a primum ASD, because this is something that is a little bit more boutique. So where I'm marked on the image on the left there, so that's the portion of the interventricular septum. And sorry, the box should be down a bit. It's down here. My images are moved. This is our right heart. This is our left heart. Our tricuspid valve, septal leaflet is situated more towards the apex. That proves to me that that's the right heart. Like that's like one of the definitions. And you can get a hole in through here. You get a little. You can have maldevelopment of this portion through here, so you end up getting blood that can flow from your left ventricle up into your right atrium. And that is what you see in an echo picture like this. So this is the Mayo orientation. It's a transthoracic, but for those that haven't seen some echo imaging online, they call it the Mayo orientation. I'm fairly sure, correct me if I'm wrong there, Rishi, but it's like everything is inverted. I don't know why Mayo does that. I think just to be fancy. I mean, I guess there's an argument that you could say it represents things more anatomically within the chest, but I've not seen anywhere use that orientation outside of Mayo Clinic stuff. And so what that translates to, if we're talking about AVSDs, is you can get this, what looks to be this complete single valvular structure, and you get some blood flow sort of going every which way. And I put a question down there that I wanted to think about. Will you see a lot or a little blood flow on color Doppler? And the answer is you're going to see very little cutting through here, irrespective of your angle, because your pressures equilibrate really quickly when you've got such a big defect. So if you've got no pressure differential, you won't get a whole lot of flow. AVSD, trisomy 21 is the common association there. Skip over that and skip over that. All right, anomalous pulmonary venous drainage. So partial or total, right? So this is where the pulmonary veins drain into the right heart rather than draining into the left heart. So if you've got a total anomalous pulmonary venous drainage, then it's a fatal lesion unless it's repaired straight away. But what you end up getting is a volume overloaded right ventricle. There are different types. The types don't really matter. They relate to where the pulmonary veins plumb. Do they plumb in above the heart, so supracardiac, or intracardiac, or infracardiac? And then type 4 is like a mix of them. But what you end up getting is you end up getting some blood flow that's come from the lungs back into the right heart to loop through that circuit again. Now, one of the things that I guess a really important point to walk away from this talk with is if you see a dilated RV or features of a volume overloaded RV and you don't have a cause, then you've got to go look for a shunt, because this one in particular is missed all the time according to the evidence that's out there. Like I'm sure I've missed it, right? Because you don't know what you don't know. But you've got more blood flowing to the right heart. There's no intracardiac shunt that you can see. There's no other cause for it. Big RV, go looking for a reason. And the most common is your upper pulmonary vein plugging into the SVC. So they have these what are called vertical veins, blood diverts around them back into the right heart. Yeah, and that's just like graphically where it can also plumb into. 80% of them will plumb into there. So 80% of them will plumb into the right, will drain to the come from the right lung, draining that way. This is a series of images or a series of short clips in this box that demonstrate pulmonary venous drainage, partial anomalous pulmonary venous drainage, and it shows how subtle it can be. So image on the left with no color Doppler, like it's just a standard suprasternal image, right? You can't really pick much being different. You can just see everything bouncing away as normal. You know, if you just see that, you think, oh yeah, fine, like it's normal. But with a little bit of tilting, if you got the right index of suspicion, so you've seen a big right heart, you can just tilt the probe a little bit and you can start to see this red flow here, flow towards the probe. You don't know what it is. And then if you open it up a bit more, you can see here that you've got some really big vessels coming through here with continuous flow. And you pulse these and it will show that it's continuous. It's systolic and diastolic flow. And these are the pulmonary veins. So this patient's got partial anomalous pulmonary venous drainage, and they're having blood flow from effectively from all their left lung. That's all the left side pulmonary veins are merging into one, coming up through one of those vertical veins and plowing back into the right heart. So it's really subtle. And the earliest changes you may see in the adult congenital patient, where it's not been diagnosed before, is stuff like right heart dilation. Hypoplastic left heart. Can anyone define this for me? Like, is this a problem in and of itself, or is this something else? Like, is this a clear, straightforward diagnosis, an independent sort of etiology? Anyone has a guess? Okay, no worries. So hypoplastic left heart is just like underdevelopment, right? It's an underdeveloped left heart and can happen for a whole lot of reasons. So I'm certainly not a fetal cardiologist, nor am I a maternal fetal medicine physician, but I know a couple of them. And hypoplastic left heart develops because of a different problem. So it's when you don't have enough blood flow through the entire left side of the circulation as a fetus. So that might be because your LV is just always malformed or hypoplastic. It can be because of a mitral valve lesion as a fetus. It can be from an aortic valve lesion as a fetus. Because if you have either of those things, you're having obstruction, you're not having full blood flow all the way through, so it doesn't develop properly. So something else quite often triggers hypoplastic left arm. And if they don't have an ASD or a PDA, if they don't have a way to shunt blood around properly to overcome the fact that their LV is small and not sufficient, then it's a terminal condition if you don't repair it. But up until that point, it's a bit self-preserving in a weird way. So if you've got significant mitral aortic valve disease, that will raise your left atrial pressure. Raise left atrial pressure will push more blood out through the ASD, so you get more blood flowing left to right through ASD. And then you've got a PDA, then you'll get more blood flowing through your PDA. So that's sort of how these babies keep themselves alive until they're repaired. The presence of the ASD and the PDA allows them to live until they can be repaired. This is a surgical repair. Those of you that have worked in cardiac surgical centers will have seen these patients come through, and the whole idea is just to try and, in a stepwise fashion, shunt blood around to repair the defect. I don't have any cool pictures of that, unfortunately. Tetralogy of Fallot. What are the lesions associated with the Tetralogy of Fallot? Anyone?
Is VSD,
Yep.
right ventricular hypertrophy,
Yep.
pulmonic stenosis, or maybe a dynamic obstruction there, and
Yep.
aortic overriding.
Yeah, very nice, right? So this is what it looks like. Where's my cursor here? So big RV, which is a consequence to everything else, really. VSD, nice one, the blood's coming in through here. Stenotic pulmonary artery, and then the overriding aorta. And the overriding aorta is, as you were describing before, Rishi, it lets blood come between that and the RV, the VSD, it lets blood come up and out from both ventricles. Yeah, normal circulation here, but this is our problem. Narrowing here, hole here, and all the blood coming out, or not all, but a lot of the blood coming out through here, less coming out through there. As they shunt it through, ultimately the aim of the game is to patch the VSD and to fix up your pulmonary stenosis. All right, anyone want to tell me what they see as we go through this? Come on, someone volunteer some words. Or else it'll just be me and Rishi speaking to each other.
I can volunteer, but if someone else wants to have a go.
Just describe what you see, that's all you got to do. Safe learning environment. There's no one, Rishi. I might put you on the spot again if that's all right.
That's all right. So here we're looking at transthoracic images. On the left, what the two most prominent features, the three most prominent features is first is the left ventricle appears moderate to severely dysfunctional. RV outflow tract is dilated, likely reduced function, and there appears a glistening structure at the junction of the aorta and the right ventricle, which could be potentially a patch repair of a VSD.
Yeah, very nice, man. Like, it's kind of subtle, and you can miss it if you haven't seen it before, right? You might go, oh, it's a bit bright, but it's very easy to miss. You've got a bit of ring down here as well, suggesting that
shadowing artifacts. Yeah,
absolutely. And again, if you watch the cardiac cycles go through, you can almost see like there's a bit of a funny sternal bounce there, or sorry, septal bounce.
Yeah.
Obviously, the causes for that is there's a lot, but having had your heart split open, your pericardium split open is one of the causes for that. Depending on what the patient's rhythm is, of course, that can be other causes too. But yeah, LV function is a bit down. RV looks dilated, and there's something right there that's going to be a patch, and that'll be a VSD patch. What do you see here?
So again, dilated RARV. There is, it stopped playing. There's a septal bounce as well. RV appears hypertrophied. Those two structures near the, I know what they are, could be some in the RA,
down here
near the IVC. Yeah, eustachian valve or some those Chiari network or something. Not sure what are those. You can put likely congenital.
Yeah, it's like I don't know what they are. I completely. First question is, are they real or are they not? I mean, they look very real to me. You can see, you might be able to see on your images, but there's little, looks like they've got a little stem coming up from them. They're moving rhythmically. You can kind of see something down here as well. Yeah, is it associated with the Chiari network? Maybe, but I wouldn't necessarily expect that to be sitting, especially this component sitting so far out here.
Yeah.
We're going to have our SBC. Yeah. So I don't know what that is in short, and I've always meant to ask, but I keep forgetting to ask someone before I do this talk. I have to find the right person to ask, which is a congenital cardiologist, and I don't know any of those. Yeah, big RV, chunky through there. That doesn't project very well, but this was just to show that, patch again. So yeah, it's a bright white thick all through here. And then what's this?
You're looking at the pulmonary valve, and there's a significant pulmonary regurgitation.
Yeah, so is that above the line or below the line stuff down here?
So these are, there's rapid pressure equalization. So there's the triangular profile instead of a parabolic curve. So there's a severe pulmonary regurg, I feel.
Yeah, so we've got, our regurgitant flow is this one here above the line.
Yes, above the line, yes.
Yeah, inversely, as you know, right? And you can, just as the sonographers calculated the VTI through this, you can do a similar thing to calculate a regurgitant volume. But a rule of thumb. Again, it's very much a rule of thumb. It's not a hard rule, but if you just think of the physics of these sorts of curves, the area under here should be the same as the area, they should match each other, right? If the blood flow is equal, then it'll be the same. So if this amount of area under here is the same as this amount of area in here, then that represents the same blood flow. So potentially, torrential looking here. I'll skip over that one. And here, in the interest of time, we've got this slither of a residual VSD just sitting in through here. You see that abnormal color flow? Yeah. Skip that right here. And again, it's that pulmonary regurg that is the classic complication of a repaired TOF, is they develop progressive pulmonary regurgitation. That's a very common American boards question, and it's a very common physician's exam question as well. Worth.
So all right, so just a quick question, Ben. So just with the pulmonary stenosis, when they repair it, how does it does the pulmonary regurg? What's the mechanism of it developing months after the repair?
Oh, good question. Why they develop it, I don't know. I'm assuming just wear on the valve, right? Like I'm assuming it's just the valve itself starts becoming competent. Okay. But I don't actually know the answer to that. That's a good question, Rishi. I don't know. Okay. I'm going to rush through a little bit because I want to get to the cases at the end because that's the funnest stuff. So coarctation, this is easily missed if you're not looking for it. And this is I really like this case because I think it shows it well. So I won't put anyone on the spot for this one. I'll just push through a little bit. So, toe images or mid-esophageal, 0 degrees. See the interatrial septum is really bowing from left to right. So think of the pressure differential there is pushing that across. I would say that the RV and the LV function looks pretty good just off these views so far. If anyone disagrees, please speak up. And come around here to our sort of almost classical, almost a sort of bicaval trapdoor view, and then come around to a long axis view. This box, I can see a bit of myself. You can see the aortic valve looks abnormal here. Again, it doesn't seem to be opening well, thinking particularly at the tips. Thinking, is that bicuspid or tricuspid? I would say I can't tell from those pictures. So you come across and you see this, bicuspid or tricuspid? Anyone?
Bicuspid.
Yeah, nice. And there you can see this, regurgitant, irregular sort of blood flow and the path it's taking as it's spiraling up and out through that outflow tract. There's some regurgitation coming back through here. You have to increase velocities through here. You see your aorta now. You're just starting to get a second glimpse of it. Doing this toes in real life, you see this, and then you start to think, oh, where are my complications of this? They're going to be in the aorta, right? Think, oh, is that a bit dilated? No, these are what, 1, 2, 3 to 4 centimeters. You see this nice sort of domed aortic valve cusp here. It's certainly staying retracted and thickened, and this one again, it looks very thick and not opening much at all. I'll come through to here, so some nice 3D shots, actually again showing that bicuspid valve, but this is the shot. So it's blink and you miss its stuff, right? Like that's it there. That's the coarct, that line. Yeah. So we often try and look at our aortas and structure that in biplane, and in my practice for doing in toe, it's sort of the last thing I do. I'll do the deep gastric, transgastric views, the mid-esophageal views, and then I'll advance the probe back down and rotate it around, biplane it, and you're looking for this. So it is that thin, this web within the aorta, and this is it in short axis, this is in long axis, and that's a coarct. Really subtle. Remember, it's going to sit just below, or in most patients, it will sit just below where your PDA would plumb in. There. That's a beautiful toe study. I'm going to just show some pulmonary valves pathology now. They should all start to play. So I've got a series of images here. So difficult to image patient. You can see that everything's a bit off axis. We don't have a nice long left ventricle. And we're starting to, you've got mitral valve here, bit of PR, here's our pulmonary valve. Can't really pick what's happening otherwise. Come in and try and get some better shots of it. This is our outflow tract through here, looking back at the right ventricle, right atrium. But when you get around to here, that's going to play as well. So this is our parasternal long axis. And we've tilted the probe just to catch that right ventricular outflow tract. And you just get this flash of mess here, right? This turbulent high velocity flow, and it's really hard to pick what's happening. You can see there's a little bit of regurgitation that just flicks in here into this right ventricle. But then you've got this big mess of stuff that's happening in through here. Again, you can't see the anatomy very well. So what are you thinking, Rishi?
I mean, there is in other views on the top right, there is like you can see the ventricular septal flattening both in systole and diastole. So there is pressure and volume overload. So I feel that if with that pulmonary recurge is giving that volume overload, and that volume when it is pumped back, is it having a flow acceleration and the turbulence? I can
So
see the RV hypertrophy in the bottom left as well.
yeah, very nice, right? So trabeculated looking RV, the septum seems to be bouncing a bit funny. But so that you can see our flash of PR, that little red flash.
Yeah.
PR is going to be a diastolic lesion. But then during systole, when you're not seeing that flash of PR, what do you think of what you're seeing down here? Where you should be seeing pulmonary trunk, pulmonary artery.
Yeah, becomes a bit smudge with the plane moving, with the probe moving, but there's definitely a turbulent flow in that area.
Absolutely. And does it look like it's turbulent flow that's in the RVOT or turbulent flow that's on the other side of the pulmonary valve?
I can't say it properly because when it just in the systole, it moves out of the plane.
Fair deal.
Can't exactly say it.
Let's see. So if we come around here, same patient, just focused more on this. So again, we've got right ventricular and right ventricular outflow tract, pulmonary valve, and it's the same orientation for every image here for everyone that's watching. So again, pulmonary valve is sitting here, sitting here, sitting here.
Yeah. So there's a reversal I can see in the pulmonary artery there.
All this, lots of turbulence as well, right? So we should have just nice, beautiful, like freely opening flow through our pulmonary valve. It should be just flowing out beautifully. But instead, we've got all this turbulent mess of color. Now, that could be because the flow is all turbulent. It could be because the valve itself, metallic or prosthetic valve, causing some artifact. But if you look at, say, this image, you can see that during systole, when the blood's meant to be flowing in, you've got this Pisa. See if I can drag it here. Yeah, right. And we talk about Pisa domes and things, and that's what we're generating off this. Again, the pulmonary regurg, that's a diastolic lesion. So this is happening in systole. So we can freeze this one as well. So again, this is our diastole. We're coming into systole. It's like, what is going on here? Complete mess, right? Complete mess with a Pisa dome there. So we think pulmonary stenosis. And again, here as well, coming down through here, we've got our branch pulmonary vessels, one this side, one that side, but this is the pulmonary valve, and this is our Pisa dome from that. So really turbulent flow by prosthetic pulmonary valve. Again, if someone's got significant PR, a TOF that was repaired as a child, for example, then it's pulmonary valve pathology they can get. regurgitation is the one as you think as the valve wears down, but stenosis can occur with any blood prosthetic valve, thrombus and pannus and that sort of thing, right?
Yeah.
Similar case, I'll just kick through this one. Won't go through, actually go back one. So in the interest of time, I'm just going to skip to these couple of things. So Epstein's is a spot diagnosis equivalent, right? So Epstein's is when the tricuspid valve is significantly further offset into the right ventricle. So the distance between where the tricuspid valve joins onto the septum and so where the mitral valve is approximates that should be less than a centimeter or so. When you get a tricuspid valve attaching much lower down here, so it makes this all of right atrium and this right ventricle, that's Epstein's. TGA. I'm going to skip to the last case I've got, and I can present all this other stuff another time. This. All right, this is one of the best cases I've found or seen at Nepean. So this will be the last case we do. If anyone wants to volunteer, just describing what they see. It's complicated. I wouldn't expect anyone to get it all without knowing the backstory. Someone, anyone? See a bunch of people online. Come on. No? All right. Well, so Rishi, please jump in where I get things wrong.
I don't know. I can only
So-
have one guess.
So
I don't know the case.
You do or you don't?
I don't.
No. So parasternal lung axis view, for those learning in the meeting, we've got left atrium, mitral valve, left ventricle, aortic valve, aorta, right ventricle. This strikes me as abnormal. It's bright white, and contractile function of the LV looks reasonable. RV looks dilated. Free wall is probably a bit thickened, but it's hard to be sure because of we're slightly tilted. But the contractile function again, he looks reasonable. Coming to the aortic valve proper to have a better look here, you've got a zoomed in box with color Doppler on. So you can immediately see there's an abnormality here with the way the color is flowing through. It's not coming through as a nice jet. Here, I think it's quite hard to appreciate how well the cusps are opening. This one here, which is either going to be our left or our non-coronary cusp, is probably a bit restricted or is a bit restricted. When we get through here, you can see it even more so. Here we've got our RV outflow view, bit of PR there, not a whole lot, but again, right ventricle, pulmonary valve, and that's our outflow tract. And here we got our RV inflow view. So we have right atrium, right ventricle, tricuspid valve. Something really bright up here makes you think they might have a pacing wire or something similar in, and we just haven't captured it very well. So right ventricular function is probably mildly down, RV is probably mildly dilated. That makes me suspicious of a surgical repair for something, and there's definitely some abnormal flow through the aorta. Importantly, the abnormal flow is not just starting at the aortic valve, it's starting in the LVOT, right? So it's subaortic abnormalities here. Come through here, and all of a sudden you can see, all right, actually this is a bicuspid aortic valve. So I'll pause this. Remember, when you're looking for bicuspid valves, you want to look at it in, I quite like looking at it in the short axis view and just go through slow. You're looking for where the raphe is and if there's the two cusps opening up like that sort of fish mouth view like we can see there. But then if you pan further down from this view, so here at our parasternal short axis view, you pan further down to start to look into the left ventricular outflow tract, sorry, the left ventricular cavity. This is our mitral valve. And that looks abnormal. If you want to hazard a guess as to why, please do. But what I'll describe is, we have our left ventricular contractile function, our systolic function looks reasonable, probably normal to be honest. Right ventricle looks dilated with reasonable function. And there's a abnormality in the mitral valve that I can't better quantify on this view, to be honest. So I've seen a subvalvular problem in the aortic valve, and I've seen a mitral valve that looks a bit funny, and I've seen a big right heart. So again here, just looking at the mitral valve, left atrium, mitral valve, left ventricle, you can see that the mitral valve's not opening fully, or at least doesn't look to be. You've got this abnormal inflow pattern, which is sort of tracking around that that sort of anterolateral wall, and that's abnormal. Come across to our aortic valve. See the aortic valve proper sitting in here, but again, there's something happening just below into the LVOT of that aortic valve. And then down here, our right ventricle is dilated, clearly dilated, heavily trabeculated. And that's what this case has got. So repaired VSD, bicuspid aortic valve. So repaired VSD, we saw the patch at the start. Bicuspid aortic valve that we saw like completely. Subaortic stenosis, which is what we're getting through here. And then a phenomenon called a parachute mitral valve, which is often an accomplice to many other cardiac lesions. Some other cardiac lesions, say with the aortic valve and the left ventricular outflow tract, will result in there being a parachute mitral valve as well. Rishi, do you know what a parachute mitral valve is? Have you heard that before?
Not really.
No.
I haven't come across.
So a parachute mitral valve is when there is effectively a single point of attachment for both leaflets. So it's when you've really got effectively like one pap muscle and all the chordae attached off that. And the way to pick it on echo is that you have this sort of funnel shaped inflow view of like mitral valve inflow. So here it sort of comes out a bit like a funnel, comes into a point that way, as opposed to opening up fully and getting just blood flowing straight in. It funnels in to the left ventricle. I think because like whoever named it, how many eons ago, thought that it looked a bit like a parachute, the way the blood was flowing in. But it's called a parachute mitral valve. Don't ask me anything about the repair of it, I don't know. But when you see your mitral valve looking like that and you're on axis, then it's a parachute mitral valve.
And on the short axis, we'll have one pap muscle at the pap muscle
Yeah,
level.
you'll generally see one pap muscle, and this study is not the short axis views apart from what I had before. Apart from this one, the quality, like the image quality, wasn't good enough to pick, so I couldn't see it very well as I was like flicking through the pictures. There wasn't a shot where they'd pan down through the alveoli to the apex where you could clearly see it. Yeah, I mean, that looks abnormal. It looks like it's not opening completely. And then on that apical views, you'll see that kind of opening up a bit like that rather than opening up nice and wide. So I've skipped over a fair bit because I've sort of done an Emma Bocock and prepared 250,000 slides for a 60-minute talk. But I wanted to come back to one, and that's this one. So for those of you that haven't seen this website, it's a really, really, really useful website. It's the best thing I've found for learning how cardiac development occurs and then learning about cardiac lesions. So bookmark it, have a look at it. It runs through all the normal cardiac development from fetal onwards, including like rotation of the cardiac tubes and L-looping and D-looping and these sorts of things. It runs through the different septal defects, and some of the graphics I've got today and have used in this presentation I've got from there, and you can have it so that it doesn't show where the blood flows, and then like you can make it show where the blood flows through and all that, and they're all listed there. There's a whole lot of other information there about cardiac development and about other cardiac issues as well, and like there's some electrophysiology stuff there too. But for congenital defects, this is the absolute go-to place from what I've found, better than any textbook I've seen. And that is where I'm gonna stop. I'll stop sharing my screen. There we go. All right, so congenital is not easy. Have a structure to it and just go through where is the blood flowing? Is it flowing into like what atrium, and then what atrium is attached, like, and then what valve is attached to what ventricle? So again, IVC goes to the right atrium, the tricuspid valve is associated with the right ventricle, and then what are the outflow tracts, and then work backwards from there. always try and get back your previous echoes to work out what they were, and that's it.
Thank you, man. It was great.
It's any questions, please ask. I'm not saying I'm able to answer them, but I can give it a shot. For interest or for reference, I suppose, some of the congenital, the obvious, some of the congenital stuff can definitely be in the American boards if you're going to see those. Expect at least a few questions on that. Certainly tetralogy and Epstein's and stuff come there before. Some significant congenital diseases come up in the DDU vivas before as well, just as the short case, like as the not short case, as the sort of point and shoot questions they used to have, like sort of here's a single or double clip about what is it. But then it's PSDs and ASDs, which you just have to sort of know backwards. And an unexplained right heart, there's a shunt until proven otherwise. That's it. Thanks, everyone. All the best, and we'll speak next week. Or someone will, it won't be me.
Thanks, man.
Thanks very much.
Thank you.